Okay. Okay. Thanks for coming back. Now, so the next chapter in the fluid and hemodynamic derangement saga is thrombosis. Now we know what it is now. It's the formation of a coagulated mass of blood in an uninterrupted cardiovascular system. That's the process of forming a thrombus, is called thrombosis. Now, and thrombus is one thrombus, yes, one coagulated mass, and thrombi is plural. So if you hear me say that, thrombi means more than one thrombus. Now, okay, you have to tell me why our blood does not coagulate now, or is it? Tell me the mechanisms behind our blood not coagulating, or is it now when we're taking notes? This is physiology, it's not pathology. How do we prevent forming thrombi? Prostacyclin. Thank you, Matt. So prostacyclin is a what? Is a what? What part of what mediator family? It's got prosta in it, so it gives you a clue. It's a prostaglandin, okay? So do you know where prostacyclin is mainly produced? I don't want to pick on you, Manny. Does anyone know where prostacyclin is mainly produced? And what it does? All right, it's mainly produced by endothelial cells. And it's a protective mechanism against anything? Anybody? Platelet aggregation. So we all know that we need platelets to coagulate. And so what our endothelial cells normally do is produce prostacyclin, or PGI2, which is a prostaglandin from their plasma membranes, and that impairs or inhibits platelet aggregation onto the endothelium. And so that's one preventative measure to stop the coagulation of blood. So that's one measure. Thank you very much, Manny. That's great. There's a few other measures. Why does our blood coagulate, or does it coagulate? There's the other question. Anybody? Physiology? No? No? Okay, look, the interaction is working now. Have you heard of anticoagulating factors? Yes, everyone's nodding. Yes, I remember those. Why didn't you tell me that then? No. Yes, we have anticoagulating factors within our bloodstream which prevent the cascade from going ahead and forming fibrin. So yes, we do coagulate. We do start the coagulation process sometimes because we initiate it, but we have these preventative or anticoagulating factors, protein C, antithrombin 3, I'll show you in a minute, which inhibits the formation of certain factors within the coagulation cascade, and we don't end up forming fibrin. So we can, yes, we do generate the coagulation cascade, but sometimes it can be interfered with. So that's one other measure. What other measures do we have? What if we actually do form fibrin? Which we all do. In fact, we're all forming fibrin now. It is broken down. Yes. Yes. Yes, Maddie. It is broken down. Excellent. You're doing a very good job today. Now, do you know why? Yep. You do know. No? No, not fibrinogen. That's in the coagulation cascade. Don't know. That's all right. We have what's called the fibrinolytic it's when you form fibrin, you generate this other enzyme called, anybody? Plasmin, beautiful. You form this other enzyme called plasmin, which dissolves the fibrin, and therefore you don't generate the coagulation, or the coagulated mass. So, yes, we do form fibrin all the time, but we're dissolving it all the time with plasmin. There's four. What's the fourth one? Which usually prevents blood from coagulating. No? We talked about it a little bit in the flow of blood in inflammation. What did we call that flow? Laminar flow. So laminar flow in itself is protective against coagulation. Because, why? Okay, what's in laminar flow? What's on the outside? Plasma. What's in the middle? What's in the middle? Cells and? Cells and? No. Cells and? No. Platelets. That's what I was looking for. Platelets. So if you've got cells and platelets in the middle and just plasma on the outside, your platelets are less likely to come in contact with the endothelium and therefore increase the risk of coagulation. So the more you have turbulent flow, where do you reckon you might get most turbulent flow? Within your vessels or structures, which in the heart and arteries, okay? Because you've got quicker flow in your arteries than you do your veins, so you get more turbulence within heart and artery, and we'll talk about that very shortly. So, I've lost my duva. It's terrible when you lose your duva. Where is it? I've lost it. It must be here. Oh, here it is. Sorry. Okay. Sorry about that. So, oh, look at that. There's your coagulation cascade. So I should have put this in the first time, shouldn't I? Because this is patented by me because I did it. Now, so to activate the coagulation cascade, we need either tissue injury, which releases a factor called thromboplastin, or collagen exposure. Always remember that. So tissue injury, collagen exposure will activate the coagulation cascade. We've got anticoagulating factors here, which inhibit the coagulation cascade, so we may stop coagulation, but if we do form fibrin, we then hopefully will produce plasmin, and as you can see here, from plasminogen, and here we have an enzyme called plasminogen activator, and there are different types of plasminogen activator. This one is tissue or TPA, which is formed by endothelial cells. We produce plasmin and we dissolve the fibrin, and that's fibrinolysis. So this is what is happening, hopefully, or all of us now, in that if we do generate fibrin, we generate plasmin, and that dissolves the coagulated mass, or the mini thrombus that we form. So, three primary influences of the formation of thrombus. And as you saw there, injury is very important. So, tissue injury of any sort, and then release that thromboplastin into the circulation can stimulate the coagulation cascade. So endothelial injury of any sort can stimulate the formation of thrombus. And let's have a look at a few things. So this diagrammatic thing, which I can get away with copyright now because apparently I'm allowed to show this. I thought for all those years that I wasn't, but apparently I am. But anyway, here it's trying to. It's not, and it's very small on yours, I know. But the endothelium, the endothelial cell is missing in this particular case. So there's an injury, so that we expose collagen underneath. So it says injury exposes collagen. It doesn't have to. Injury can cause release of thromboplastin from cells as well. But you can see here that platelets stick to that collagen, activate the coagulation cascade, and we end up forming fibrin, and we get what's called a platelet plug, where we form fibrin and platelets together, and this is really a mini thrombus that we're forming here. So, exposure of collagen or injury to cells of the endothelium can actually stimulate the coagulation cascade and can end up forming small thrombi first, and then they can get bigger after that. Here are some lesions on the arterial side which increase the likelihood of the formation of thrombus, and we'll just go through them. So a mural thrombus. Mural just means wall of the left ventricle, myocardial infarct. So why do you think that you're going to form thrombus here on top of that myocardial infarct? Turbulent flow. We haven't even got to that, Juliana, but that's excellent. The turbulent flow, you're thinking ahead of me. Wow, beautiful. But in regards to what we're talking about now with endothelial injury, it's a double effect in all of these, really. It's a double effect. So we've talked about endothelial injury. So remember, the endothelium also covers the chambers of the heart, as well as the valves. So we're initially injured, so with thromboplastin released from the cells. But what happens later? Yeah, but what happens later in the heart? What might happen later in the heart if it's healing? Scar tissue. I'll show you a picture very shortly. So scar tissue exposed to the chamber. Not only is there turbulence, but there's also collagen exposure to the circulation, and that increases your likelihood of thrombus. Heart valve diseases, endocarditis in this particular case, probably mostly from anybody. What would your endocarditis mostly be from? Etiology, cause. Endocarditis in your heart valves. Anybody? Bacteria? Yep, a bacterial infection. You get a septicemia. The bacteria lodge on your heart and then you can end up being chronic, and you get a scarring, and it's the collagen and the turbulence that increases your risk of thrombus. These other ones, which Seb will be doing in his video, is atherosclerosis. And atherosclerosis is disease of your arteries where you deposit cholesterol, and from that you can cause ulceration, which then can expose collagen, but as you'll see, you can also create turbulence. Aneurysms, with a Y, are ballooning or outpouching or weakening in the wall of vessels, but particularly arteries, and that's an aneurysm there. And most aneurysms, I'll show you this in a real, I'll try and get some human specimens in our workshops coming up, and I'll show you a good aorta, well, not good aorta, but it's a bad aorta really, that has all of this. And most aneurysms, weaknesses occur at the bifurcation of the abdominal aorta and the iliac arteries around here, because this is where what do you think most is happening here? What sort of things would increase the risk of, say, damage to your endothelium? What things would damage at there? Two main things. What do you think might damage the walls? Not trauma, Mitch, no. High blood pressure, thank you, Georgia. Excellent. And what we've just been talking about. Turbulence. So most turbulence occurs at bifurcations, and that causes damage to the endothelium. Turbulence in itself can damage the vessels at the branches. So high blood pressure, hypertension, and turbulence increases the weakening of the wall. Sometimes you'll definitely get atherosclerosis from it, and then the thinning of the wall to cause an outpouching in the wall. And we'll talk about the problems that are associated with that soon. Now, what is not mentioned here, and it should be, and basically because it's not a lesion of such, and Seb will be talking about this when he talks about stroke next week. One of the most common forms of stroke is from a thrombus travelling from a thrombus being formed in the heart due to what's called atrial fibrillation, or you get spasm in the atria, and that spasm is massive turbulence, and that massive turbulence then increases the risk of thrombosis, and that can travel to your brain and cause a stroke from that, or it can cause other things, as we'll see. So these thrombi in all of these different places that we... Oh, but there it is, there it is there. Oh, no, never knew it. There it is. I didn't see it. It is there, atrial fibrillation. And that thrombus can break off and travel, and we can talk about what the problem with that and what the term is for that very shortly. So that's on the arterial side and the heart. So there you go. Here's a picture. An old myocardial infarct, the thrombus formed on scar in an old myocardial infarct. So you see the scar? Remember, scar tissue by the naked eye is white. Now this stuff here is not cardiac muscle. That is thrombus. Coagulated, and it's because of two things. Yes, turbulence, Juliana, yes, and the exposure of collagen from the scar. So this is cardiac muscle there, which doesn't look that good actually, but that is scar tissue there, and here's your thrombus. On top of atheromas, and as I said, Seb's video is coming up shortly. These are what are called ulcerated plaques or atheromas. Again, exposure of collagen and turbulence increases the risk of formation of thrombus. Here is a coronary artery, again, due to turbulence and atherosclerosis, ulcerated atheroma, and that coronary artery is completely filled with a thrombus. So there's endothelial injury, and we've sort of talked about the next one, we have, in relation to turbulence. So turbulence, as the name suggests, creates, for want of a better word, whirlpools, or what's called eddy currents. And all they are, really, is pockets of stasis. So where do you think we mostly just get stasis in our vasculature rather than turbulence? In our veins. So in the veins, the blood flows slowly, and so we can get to a point where we can get static flow, and that, by having static flow, that increases the likelihood of things like laminar flow not occurring, and so platelets can touch endothelium, and that can instigate the coagulation cascade. So everyone knows that if you go on a long trip overseas and you sit for too long, you increase the risk of developing thrombus. Did you know that? Yeah, we all know that. It's, what is it, economy class syndrome. No, it's true. No, I'm not being funny. It's true. So, and what happens by being static or stagnant for too long, you pool your blood, and that increases stasis, and that increases the risk of the coagulation cascade being generated, and you form a thrombus usually in your deep leg veins, but in any veins you can stimulate the formation of thrombus. While turbulence, again, as we've said, is on the heart and arterial side more so than in veins. And it's all the same principle. Turbulence creates static flow in those eddy currents or whirlpools, and so that increases your risk of developing thrombus. Can you see that? Good. Okay, so here's a picture of a valve. There's valves in veins. There's no valves in arteries, I don't think, unless... Is that right, Chris? Yes, good. Now, we'll come back to this, don't we? So there's a valve in... Yeah. Oh, no. Oh, I was going to ask... did you see that? No? The question that I normally ask, well, where do you think that the initiation of the thrombus would come from? And I'd go, would it be here? And you go, yes. And I say, no, you're wrong, because it is mainly there, because that's where most of your stagnation occurs in your veins. So the initiation of the thrombus starts behind the valves. You've probably got that there anyway, haven't you? Yeah. I should throw that one out. But anyway, now look at this one. This is a deep leg vein thrombus, and that is I think it's a thigh, and there is your deep leg vein, which would be femoral. Yeah, femoral vein. And as you can see there, as I said before, some of these can be, up to, 60 centimetres long, maybe more, and have a diameter of maybe up to 2 centimetres. And you could see the consequences of that before in that lady's leg. I think it was a lady, not too sure, but a person's leg before. And this person's obviously died from something, and we'll talk about what the most likely cause of death through to this. So these things can break off and travel, and that's your real big problem. If they break off and travel, that's when you start to worry. You're worried enough if it's still localised into your vein, but if it breaks off and travel, well then you've got lots and lots of problems. Varicose veins, on the other hand, are superficial veins. They are clinically important, and you do get thrombosis, but you're less likely to have the complications associated with deep leg veins. But there still can be problems. They can be knocked, they can be ulcerated, and you can get thrombus being formed within those varicose veins as well, which are obviously superficial veins rather than deep veins. So this is all to do with, that was stasis, and this is stasis and turbulence. So an aneurysm not only can occur in blood vessels, such as the arteries, which is mostly they're seeing, but we can get aneurysms within the heart. So this person's had an old myocardial infarct, you've got a weakening of the wall, and you've got bulging of the wall of the ventricle. And so here we've got scar tissue, and here we've got a thrombus being formed. So not only have you got scar tissue, but you've also got massive amounts of turbulence, and that increases the risk of your thrombus being formed. So when you get your question on your online tests, is that here is a double effect: collagen exposure and turbulence causing the formation of the thrombus. This is a really interesting one. So this is the abdominal aorta, okay? And in this region here, clinically, they're the most important lesion as far as atherosclerosis is concerned in elderly individuals, where you get bulging or weakening of the wall of the abdominal aorta, usually around the bifurcation of the aorta at the iliac arteries, at that region. So here, cross-section of your artery, and I'll show you. There's your aorta, the lumen of the aorta, and this is the thrombus that is formed. So again, this is turbulence and scar or collagen increasing the risk of the development of thrombus. And if we look at this is the actual, I'm pretty sure, you can actually see the aneurysm there from the outside in this elderly man here. So you can imagine that the complication from that, what would be one of the major problems with just the aneurysm in general without the thrombus? What do you think? Rupture. So rupture is a really bad thing, but as we'll see, what else do you think from the thrombus? From the thrombus. Anybody? We'll find out. We'll find out very shortly. You probably can work it out. The other primary influence is hypercoagulability of the blood. So there are many different clinical situations. Can you give me a few? Anyone? We've done one last week. Cancer, thank you. Certain types of cancer. Certain cancers can release thrombogenic agent. What's that syndrome called? Anybody? Could be on your exam. When a cancer produces something to para something. Yes, it is a para something. Paraneoplastic syndrome. So where a cancer produces a protein or something else that causes other effects rather than the cancer just eating into something. So, yes, it's paraneoplastic syndrome. What other hypercoagulable states do you think? All right, people that smoke. The elderly. And it's all to do with they increase their risk of coagulation. So that's why the elderly need to take aspirin to try and thin their blood more, because they're more inclined to coagulate. People that have had trauma. So any large trauma, thromboplastin being released. So large trauma, say road accident victims, really important. Tissue injury factor being released because of the injury. Just breaking of bones increases the risk of not only thrombosis, but also what we'll find out is fat embolism. Fat can actually get into the circulation and cause problems in large fractures. Burns victims. Extensive burns can, again, think thromboplastin, increased tissue injury factor. So, smoking increases the risk of blood coagulating. Lots of other things. Certain medications. There's many, many different causes of hypercoagulable blood. And coming back to all of that is that the endothelial injury can be things such as cholesterol, can be things such as components of tobacco smoke. Anything that damages the endothelium can also cause hypercoagulability of the blood as well. So there are many, many different reasons. So the fate of a thrombus. Okay, blank. What do you think the most common fate of a thrombus is? Blank. Blank? Yeah, blank, yeah. Most common fate of a thrombus. Yeah. But did anyone hear Fiona then? No, good. Okay, no one heard it. All right, anyone else? It gets broken down. So lysis, because most thrombi are small and we generate plasmin which will dissolve it. Next most common is propagation, meaning it gets bigger. And it can get bigger both in veins and arteries or even the heart. So here we go, we'll do a propagation of a thrombus in a vein. Here we go. I spent hours doing this, maybe days. Here we go. Oh, and there it is. So what happens is that the thrombus first grows forward and then back. And that's a propagation of the thrombus. So it gets bigger. And as we saw with that one in the deep leg vein, it would have started off small, but then propagate to get much, much bigger. The other fate of a thrombus is obviously, I think, breaking off and travelling. So anything that's... Now, my definition of an embolus, which is not probably what they're going to put in the medical dictionary, but I like it. Something that normally doesn't travel in the bloodstream. How easy is that? They don't say that in the medical dictionary. They'll say some convoluted thing, like I do with the thrombus. But an embolus is something that travels in the blood which shouldn't. An emboli is plural. Now, this is where the Herald Sun completely get it wrong. They will call an embolus something that lodges in, say, the lung, but it's actually an embolism. So where the embolus or emboli lodges, that is the embolism. Okay? Yeah. So, embolism, where the embolus or emboli lodge. And we're going to talk about that very, very shortly, and the common problems associated with it. The other really interesting one is that in the heart, we saw with the aneurysm or with the other aneurysm, is that thrombus can, well, remember it's containing fibrin. Fibrin will stimulate what? It will stimulate cell division of endothelial cells and fibroblasts in the surrounding vessel to migrate in, form granulation tissue, form scar, and therefore get incorporated into the wall as scar tissue. So the healing process or the repair process can occur. But the problem is, what's the problem always? If it's in the heart or if it's in the artery, What's the underlying problem always? It's going to increase your likelihood of forming thrombus because you've got scar tissue being exposed to the blood vessel, to the circulation all the time. So that's your real problem, and that's why you would have to go on blood thinners of some sort, anticoagulating things such as warfarin or similar, so that you wouldn't increase your likelihood of thrombus because of it. The other one, the really interesting one, is recanalization. And this is the only time when granulation tissue remains granulation tissue. It doesn't get converted into scar. So, for instance, if that thrombus changed into granulation tissue, which it can, and there it is there straight away, I've changed it into granulation tissue, by endothelial cells, fibroblasts migrating in from the wall, you can actually reconstitute blood flow back into that vein or artery. I've seen them in coronary arteries where you can recanalize the blood flow. And the amazing thing is that you can see that the vessels align themselves in the direction of blood flow. It's quite remarkable. And so you form, and I've done a really bad thing. This is not in yours. Vein with the thrombus in cross section, which is a bit of a lie, all right, because it's just blood. But we'll just, for our purpose, it's a thrombus, right? And then when you get recanalization, you get little capillaries to reconstitute flow through that vessel. It's quite amazing, and it actually, yes, it does happen to reconstitute blood flow. All right, so they're the fates of a thrombus. So what about embolism? That is when a thrombus travels and lodges far away. Now, as I said before, an embolus is something that travels in the blood which shouldn't. So, what do you reckon is the most common embolism, or embolus, I should say? What's the most common embolus? No, what's the most common embolus? What's the most common thing that travels? And we've been talking about them. We've been just talking about them. Or what are those things that we've been... What's that stuff we've been talking about? Thrombus, that's right. So, yes, so the most common embolus is a thromboembolus. But we can have other emboli as well. That's what I'm trying to get at. What other emboli do you reckon we could have other than thrombus? Bacterial vegetations. Thank you, David. What else? Cancer. Cancer cells travelling. What else? I just mentioned one before, fat. Quite common. If we break the marrow, and fat can get from the marrow into the circulation. Anything like injections of any sort into the bloodstream is classified as an embolus. Even something like gas, air or nitrogen, the bends, that'll do. But 99%, or maybe I'll call it 98.5%. No, we'll say 99% of emboli are thromboemboli, but we can have others as well. So, what do you think the most common embolism is now? What do you think the most common embolism is? Or clinically relevant embolism is? No, it's not stroke. It's not stroke. That'd be fairly high up there, but... Okay, we're thinking, where would most emboli come from? Where would most emboli generate from what we've been talking about? Of what we've been talking about? It's not the heart, no. Yes, the veins, because it can happen in individuals that might have just poor circulation. So usually deep leg veins. So which organ, therefore, would be most compromised in an embolism, and particularly in people in hospital? No, not the heart. Not the brain. The lungs. Okay. Oh, it's in front of you. pulmonary embolism. So, deep leg vein thrombus, pulmonary embolism in people in bedridden, in hospital. This is the most clinically relevant complications, pulmonary embolism. Okay, so outcomes? What would be the most common clinical outcome? Blank. You've got a blank. Most common clinical outcome of a pulmonary embolism. So thrombus is broken off, travelled and lodged in your lung. No, not hypoxia, no. We said it before. Lysis, yes. Which therefore would have no clinically, so it would be clinically silent. So most thrombi might be quite small. They travel, lodge in the lung, get dissolved. Clinically silent. Good, hey? So that'd be good, but unfortunately you can drop dead as well. And there you go, sudden death. The percentages, I'm not quite sure, I've forgotten. I think, no, I'm not even going to hazard a guess. Yes, I will. 5%. How's that? I'll say 5%. I should know. I think clinically silent's about 70%. And sudden, don't write them down. When you look at the bulletin notes, you can see them, what the percentages are. But I think it's about 5%. Do you reckon that sounds all right, Chris? 5? Yeah, okay. So 5. Let's have a look. So what happens, what do you think people that drop dead suddenly, what do you reckon, what would be the embolus that would, do you reckon it'd be small? No, it'd be large. So yes, normally when people die of a pulmonary embolism, it's due to a very large thrombus breaking off, travelling, going up through the inferior vena cava, through the right side of the heart, to the pulmonary artery where it straddles the bifurcation of the pulmonary artery. It can't go any further. There's no blood going to the lungs and the person drops dead straight away. And it's called a saddle embolus. And here it is here. I don't know whether I can turn I'll turn the lights down a bit. You don't mind me turning the lights off, do you? Here we go. Off. Lights off. Oh, here we go. Okay. So if we have a look here, you can just see, it's not all that clear, but this is the size of the thrombus, which is backpedaled on itself, and this is the bifurcation of the pulmonary artery there, and there is your saddle embolism. Okay? So it is an embolism now, not an embolus. It was an embolus, but has now become... And so there's no blood that can actually supply the lungs, and the person, there's no blood flow, so the person drops dead. You can, however, you can also get infarction. And this is an infarct of the lungs due to a shower, probably quite a large embolism. And again, it'll probably be a thromboembolism. The question I'm going to ask you now, which most students do not get right, okay? Why is it difficult to infarct the lungs? All right. Because what I've told you here is that the thrombus has broken off and travelled to the pulmonary artery, and it's blocked the pulmonary artery. What can you tell me about the pulmonary artery which is different to any other artery in the body? What was that? It carries deoxygenated blood. Okay, now here's the question. What supplies the lung with oxygenated blood? And no one gets it right. For the last 30 years, I have asked this, and no one has ever got it. Because you're not ever taught it. Anybody? I've had students say, oh, you just breathe in and the oxygen gets in your lungs. And that's it. That's how you get oxygen into your lungs. And that supplies it. And it's not bad. Well, I think, yeah, that's not bad thinking, but it's wrong. Oh, yeah, oh, Brooke knows. Yeah, you know, don't you? Yeah, I've told you this before, haven't I? No. No, tell me. The bronchial artery. Yep, correct. Well done, Brooke. The bronchial artery, which comes off the aortic arch, supplies the lung with oxygenated blood. So if you have small embolisms within branches of the pulmonary artery, you may not get an infarction because it's deoxygenated blood and you're supplying your lung with oxygenated blood quite normally. So the lung is very difficult to infarct because there's two arterial supplies. One, deoxygenated blood. Two, oxygenated blood with the bronchial artery. Okay? So there you go. You learn something every day. So, however, some people can get infarction. What do you think those people would be... What sort of person do you think that would be more prone to lung infarction then? You're not being... Come on, say it. Yell out. What is it? No, well, yeah, anybody that has a poor circulatory system of some sort, where they're not supplying enough... Yeah, they're not supplying enough blood to any tissue, including the lungs. So if you've got a poor circulation of any sort, well then, and elderly individuals come into that as well. You can just get hemorrhage. So hemorrhage without infarction, meaning that you get a thrombus, it blocks the artery bursts, but you're still supplying with oxygenated blood, so you don't get an infarct. But you just get a hemorrhage, but you can get infarction, you can. And again, have a look at the percentages. I'm not quite sure, I've forgotten what they are. But infarction can occur, but only when you may have a very, very large share of embolus or a large embolus, or you've got a poor bronchial circulation to supply the oxygenated blood to cause infarction. You'll definitely get a question on that. Why is it difficult to infarct your lungs in your exam? No problem. Huh? So, there is a fifth one, but you can read up on that. We won't worry about that. Cause pulmonary hypertension it can cause as well. Okay, what about systemic embolisms? That is, embolisms which where usually the thrombus has been in that arterial side of the heart or the arteries, where we saw the thrombus before. Okay, here's a question. Look at them all. Okay, here's a question. Again, this is very pertinent to exams. Now, have a look at all these tissues, right? You got them? Yep, all right. Soaked it all up? All right, of those tissues, which would be the most susceptible to infarction due to a thromboembolism, and which would be the least probable to get an infarction? Which of those tissues? So the most susceptible and the least susceptible. Okay, what would be the most susceptible? Not the heart. Incorrect. I'm trying to ignore Fiona because she's answering all the questions right. Anyone? Only one person has said it. And that was Fiona down the front, I think. And it is the retina. The reason why it's the retina is because it's the smallest artery and there's only one artery that supplies the retina. So if you block it, you'll infarct the whole of the retina. All of the others, you can get some form of protection. Even in the heart, you can open up collateral circulations if you block one branch of the coronary artery. And as we'll see in the brain, the base of the brain, you have a structure called the circle of Willis, which is circular, which is good because when you block one branch of it, the blood can flow around the other way and supply the brain that way. So all of those other ones, there are protective mechanisms. Even in the lower leg, you may have even though you have an increased risk. So I'll show you an infarcted foot pods coming up very shortly. Okay, the least susceptible then. Dietetic students should know this. No, it's not the kidneys. It's the intestines, the small intestine. Because it has a... Did you know that one too? No, there you go. Small intestines are most protected because it has an enormous good anastomotic blood supply or collateral circulation. So here, this is, for instance, this is maybe the kidney or the spleen. And what normally happens in a thromboembolism of the kidney or spleen is that they have these things called end arteries, and when we block one branch, it only kills off one section of, say, the kidney or spleen. So infarction in the area supplied by blocked artery. Okay? So you don't kill off the entire tissue. And the kidney and the spleen can still function. It usually only happens in a segment. While in the intestine, if you blocked off, say, a branch of the mesenteric artery, you've got other branches that can supply the tissue. So this is exactly what you see in the intestines, is if you block off that branch, well then these can supply the other. So that's a good prevention of infarction by collateral circulation or anastomotic blood supply. So there you go. So intestines, though they can infarct, and I'll show you a picture of an infarcted intestines as well. So PODS, that's for PODS, infarcted foot from a systemic embolism. So probably where you most likely that would have come from. Where would the embolus come from? Thromboembolus? From where? From where? Where do you reckon mostly? Could be a couple of things. Where? Hurry up. Not the right side. No, not the right side of the heart. It has to be your left side of your heart. And it has to be either from a myocardial infarct with a thrombus on top of it, so it has to be quite large, or from, say, an aneurysm, abdominal aortic aneurysm, the thrombus is broken off and travelled. There's your kidney infarct, as you see, a section, only a section of the tissue is killed off. Heart, we've seen this one before. Heart has a fairly intermediate collateral circulation. You've got 3 arterial supplies, as Seb will allude to when he does myocardial infarction. But this person has died from myocardial infarct, basically from a very large thrombus, probably superimposed on top of a atherosclerotic plaque, and we'll find out about that later. Here is an infarction. Yes, you can get infarction of your intestines as well, and that may have been possibly, I'm not going to hazard a guess, but it could be from a large shower of thrombus from the heart, for instance. We've got some good case studies coming up about infarction of the intestines as well. Yes, the brain, and Seb's going to do, next week he's doing stroke, and this is stroke, a cerebral infarct. This person's obviously died. Most common form is from a thrombus from arterial fibrillation, formation of thrombus from arterial fibrillation travelling and lodging, but doesn't always have to be. There are other instances as well. Now the brain is protected at the base of the brain, outside of the brain, from this structure called the circle of Willis. So if we get a thrombus breaking off, say from the heart and travelling and lodging, it could lodge in this, anywhere in the circle of Willis, which supplies the brain at the base of the brain. So you could get a thromboembolism, say lodging here, for instance. Now if it does, the blood can flow around this way and then supply the brain. But as you can see, if you've got a shower and may block both sides, then you're not going to get the circular flow into the brain. So this circular structure called the circle of Willis is in fact protective of stroke in a way. Well, it definitely is, because you can get circulation around the other way and supply the brain from the circle of Willis. Okay, I think that's it. So there's a video that goes for about 9 minutes on infarction, and I'll put that up after this.